Hey guys, welcome to another episode of Life with Juan. It's me, Juan, and I'm back from the hospital watching Mama Dr. Joan.
More than 100 hours into pregnancy in the air.
And I've never admittedly had a patient who was a flight attendant that was pregnant, but
Hers is one of the YouTube channels that I'm subscribed to. Her videos are awesome, guys. You should totally subscribe. You guys should totally watch it if you're a med geek. Anyway, because I was watching Mama Dr. Jones, I was thinking, maybe I could play a game related to pregnancy. So let's play another game of Prognosis. So, in Mama Dr. Jones's latest video, she was talking about a flight attendant who got pregnant. And now, I don't personally feel nauseated when I go on a flight, but I'm sure a lot of people do. And so because of that, I'm going to play this case called Nauseated. So, okay, let's start. A 27-year-old primipara presents at 12 weeks of gestation with recurrent, severe nausea and vomiting. By the way, primipara means she was pregnant for the first time. She's also lethargic and weak. She was diagnosed with Hyperemesis gravidarum, hyperemesis meaning she's vomiting a lot, 2 weeks ago, which was managed with IV fluids and antiemetics. No underlying medical disorders were detected. An ultrasound scan at the time showed a single live intrauterine gestation of 10 weeks. A full blood count is found to be normal. Alright, let's do our physical exam. The mom was lethargic, pale, weighed 62 kilograms, and had a height of 163 centimeters. She had dry oral mucosa, increased skin turgor, a capillary refill time of less than 2 seconds, and no asterixis. Asterixis. I honestly don't know what that word means. Let's look it up. Alexa, define asterixis.
Asterixis is usually defined as an abnormal muscular tremor characterized by involuntary jerking of the hands or an abnormal muscular tremor characterized by involuntary jerking of the hands.
Alexa, thank you.
Anytime Juan.
There you have it, no asterixis. Her hands' movement was perfectly normal. For her central nervous system, she was conscious but confused, she was inattentive, she had poor judgment, and her memory was not impaired. For her cranial nerves, she had bilateral lateral rectus palsy. These are the muscles that turn your eyes to the side, and bilateral mild vertical nystagmus, meaning that when you turned her head up and down, her eyes would shake vertically. But her other cranial nerves were normal. For her upper limbs, she had no sensory or motor signs. However, she had dysmetria. Dysmetria meaning she couldn't judge distance properly. For her lower limbs, she had no sensory or motor signs again, but she had a bilateral positive heel-to-shin test. My friend Barry will demonstrate. This is my friend Barry. Hello! So Barry's going to demonstrate the heel-to-shin test. You'll ask the patient to lie down and strike his heel to his knee. Then you'll ask him to slide his heel down his shin. Slide his heel down his opposite shin. Just like that. Maybe you could tell him to repeat it a few more times. Anyway, in a normal test, the heel will go down very smoothly. However, in a positive heel-to-shin test, your patient's just going to do this. Your patient won't be able to follow your instructions properly. That could be a sign of something being wrong with your cerebellum or the blood vessel supplying it. Okay, thanks, Barry. You're welcome! So our patient had a positive heel-to-shin test bilaterally. Finally, she had ataxic gait. That means she couldn't walk properly. Down at the bottom, I have no idea why it's there, are the vitals. That's because vitals usually come first. Her pulse was regular at 88 beats per minute, so that's normal. Her blood pressure was 135/75 mmHg, with no postural drop, meaning it didn't change with a change in posture. Her heart and lungs were normal, and for her abdomen, she had a fundic height of 13 centimeters, and she didn't have any organomegaly. Okay, now that we've studied our case, let's go and investigate. I think we should do a liver profile. She has increased AST and ALT at 152 and 158, but her bilirubin is normal, her ALP is normal, her albumin is normal, and her INR is normal. Let's check her urine for ketones. Yep, there are ketone bodies in the urine. Let's check her metabolic panel. Okay, so her potassium is normal at 4.7, her sodium is normal at 142, her blood urea is also normal at 6, her creatinine is normal at 0.7, and her glucose is normal. Let's do an MRI of her brain. Okay, so T2 is an imaging on MRI that highlights the fluid parts of your brain, as we in med school say, World War II, or water is white on T2. So it shows enhancement of the medial thalamus and the inferior colliculus. The thalamus is an organ that's important for synthesizing sensory and motor function, while the inferior colliculus is important for hearing and auditory input. Alright, so now that we've done all of that, let's manage our patient. I think I will give her IV thiamine. Thiamine is vitamin B3. Should we give her glucose? Nah, her glucose levels are normal. I'll definitely give her IV fluids because she's been vomiting. Has she? Yep, she's been vomiting. Antiemetics. Maybe I won't give her antiemetics. I don't think it's necessary at this point. Are we done? Let's go. Almost there? Where did we go wrong? Oh, I should have given her antiemetics? I did treat the complication of her vomiting. Maybe I should have treated the symptom itself. Let's check the explanation. So this young lady has presented with recurrent severe nausea and vomiting. Priority should have been to evaluate her hydration and hemodynamic status and resuscitate her if necessary. Note the presence of dry oral mucosa and decreased tissue turgor, shown by her dry mouth. Wait, I thought she had normal capillary refill time. I wish I could go back to the history at this point. This indicates that there's some degree of dehydration. However, her vital parameters are stable and capillary refill time, I was just talking about that, is within normal limits, indicating that she is not severely dehydrated. Thus, definitely I did this, IV fluids should be commenced. Note that oral rehydration is unlikely to be successful in view of the nausea and vomiting. With a recent history of hyperemesis gravidarum, this is most likely a recurrence. While certain medical conditions can also present similarly, these have already been ruled out in the previous admission. Or should we assume that? I'm overthinking. I was told earlier that I shouldn't overthink too much when seeing patients. Let's move on. Similarly, pregnancy-related causes such as molar pregnancy should have also been excluded, or rather, have also been excluded. However, it's essential not to cease her evaluation here. HEG, or hyperemesis gravidarum, can give rise to a variety of complications, and it's important to assess each and every patient for the presence or absence of these. Thus, a careful examination reveals the presence of altered mentation, inattentiveness, and poor judgment, suggesting that she's in a state of encephalopathy, or central nervous system problems. Neurological examination further demonstrates the presence of ophthalmoplegia with her bilateral rectus palsy, dysmetria, and an ataxic gait, i.e., a mix of motor and cerebellar signs. The causes of encephalopathy in HEG are manifold and include hypoglycemia, severe anemia, liver failure resulting in hepatic encephalopathy, renal failure giving rise to uremic encephalopathy, and rarely central pontine myelinolysis or Wernicke's encephalopathy. Confusion, ataxia, and ophthalmoplegia are known as the classic triad of Wernicke's encephalopathy, making this the probable diagnosis. Note that while central pontine myelinolysis can also present in this manner, other neurologic features such as horizontal gaze paralysis, spastic quadriplegia, and pseudobulbar palsy are also often present. Unfortunately, the other conditions listed above can also overlap these symptoms, and signs are considerably more common.
Tomorrow there are 3 events.
Alexa, be quiet. And are very difficult to completely exclude clinically. Thus, further investigation is essential. The normal serum glucose immediately rules out hypoglycemia. Mild elevation of transaminases seen in the liver profile is compatible with HEG. Note also that the INR, bilirubin, and albumin are all within normal parameters, making significant derangement of liver function unlikely. Her renal function, electrolytes, and full blood count are also normal. Thus, Wernicke's encephalopathy remains the probable diagnosis. At this point, it's important to immediately start IV thiamine, as this will essentially reverse the disease. I remember you give thiamine for Wernicke's encephalopathy. MRI imaging of the brain is valuable in providing evidence supportive of Wernicke's encephalopathy. T2 weighted image in this patient shows enhancements of the medial thalamus and inferior colliculus, which is highly compatible with the diagnosis. Note that solutions containing glucose should be avoided in patients with Wernicke's encephalopathy, as thiamine acts as a coenzyme in the metabolism of glucose. That makes sense, because to metabolize glucose, you use up thiamine, and it's going to compete with use by the brain. Thus, this may use up any remaining reserves of thiamine and result in further worsening of the condition. So HEG is defined as extreme, persistent nausea and vomiting during pregnancy, resulting in dehydration. Between 0.5 to 2% of all pregnancies are affected. Many of these women require hospitalization. The underlying pathophysiology is still unknown. However, physiological, psychological, and even sociocultural factors are believed to play a role. The most popular theory is that HEG is linked to the increased levels of human chorionic gonadotropin encountered in pregnancy. Evidence in support includes the higher incidence of HEG in women with multiple gestations and molar pregnancies, where HCG levels are markedly high, as well as the fact that HEG is most common in the first trimester, where HCG levels reach a peak. It has been proposed that HCG stimulates the thyroid gland, as the protein structure of HCG, I've said that so many times, resembles that of TSH, resulting in a transient state of hyperthyroidism, which is called transient hyperthyroidism of hyperemesis gravidarium, TTHG. Several other hormones have also been proposed as potential etiological factors. These include estrogen, placental serum markers, adrenocorticotropic hormone, cortisol, growth hormone, and prolactin. Recently, chronic infection with Helicobacter pylori has been implicated as a potential cause of HEG. Known risk factors for HEG include multiple pregnancy, gestational trophoblastic disease, nulliparity, obesity, a history of migraine, and a history of HEG. Universal features of the disease, which typically starts between the 4th to 10 weeks of gestation and resolves by 20 weeks. Rarely these may persist into the second trimester or throughout pregnancy. Vomiting is usually intractable, resulting in dehydration, electrolyte imbalances, and weight loss. Other nonspecific clinical features include fatigue, weakness, dizziness, distress, irritability, labile mood, and depression. The physical examination is usually unremarkable. However, special attention should be paid towards the vital signs of the patient. Complications of HEG are numerous and include weight loss, dehydration, electrolyte imbalances. I meant electrolyte, not electrolyte. Acid-base disturbances, muscle weakness, and psychological disturbances. The most severe, but fortunately rare complications include end organ failure, particularly liver and renal disease, esophageal rupture, Mallory-Weiss tears, Wernicke's encephalopathy, central pontine myelinolysis, retinal hemorrhage, renal damage, and spontaneous pneumomediastina. Fetal complications due to HEG are fairly uncommon. These may include intrauterine growth restriction, miscarriage, and even fetal death. The diagnosis is made on clinical grounds via careful observation. However, it's important to rule out other common illnesses which can mimic this presentation. These include urinary tract infections, acute hepatitis, thyrotoxicosis, hyperparathyroidism, diabetic ketoacidosis, Addison's disease, appendicitis, cholecystitis, pancreatitis, and peptic ulcer disease. Note that the presence of a viable intrauterine pregnancy should be confirmed. Thus, an obstetric ultrasound scan to rule out gestational trophoblastic disease and neoplasms and determine if a state of multiple pregnancy is present is mandatory. Several basic laboratory investigations are also useful in the management of these patients. A full blood count will typically show an elevated hematocrit if dehydration is present. Testing for urinary ketones should be performed daily to evaluate the severity. Serum ketone body levels can also be estimated simultaneously. It's particularly important to note that high ketone levels are harmful to the fetus. Serum electrolytes should also be performed on a daily basis to detect if any electrolyte imbalances develop. These acid-base balance and renal functions should also be checked regularly. Note that liver transaminases are mildly elevated in the majority of patients with HEG and are alone not a factor for alarm. A simultaneous psychological assessment is extremely important to detect any psychological disturbances. The management of HEG mainly consists of supportive care and should be individualized based on the severity. Women who are severely dehydrated with high levels of ketones require IV fluid therapy, along with supplementation of vitamins, particularly pyridoxine and thiamine. Pyridoxine is vitamin B6. An input or output chart should be maintained in all patients. Their nutrition, fluid, and electrolytes should be adopted and titrated against the available investigation results. Note that solutions including glucose should be avoided until any coexisting metabolic derangements are corrected. Antiemetics can be administered intravenously or rectally and changed to the oral route when the patient is able to tolerate them. Drugs commonly used include phenothiazine, metoclopramide, and ondansetron. While there is limited evidence with regard to teratogenicity, it's important to appreciate that avoiding antiemetics may potentially result in more harm to both mother and fetus. Methylprednisolone should be reserved for women whose symptoms are unresponsive to other treatments, and this should only be used for after 10 weeks. Treatment with ginger have also been proven to be effective in reducing symptoms. Psychological support is also extremely important for a faster and better recovery. In general, the prognosis of uncomplicated HEG is excellent, with the majority of patients recovering completely. However, psychological morbidity can be high, with 60% of women developing secondary depression. Okay, for the take-home messages. HEG is typically a disease of the first trimester, although rarely, it can persist throughout pregnancy. The management of HEG primarily consists of supportive care and should be tailored to each patient. And finally, it's essential to appreciate that there is high psychological morbidity, with many women developing secondary depression. And that, my friends, was Nauseated. I'll admit that it was quite a mouthful. As you might have noticed, I was mispronouncing several words. But we finally did it. We finally read it, and we finally managed this patient. Awesome! Please like and share this video, and if you haven't, subscribe and like the bell icon. Click the bell icon. And finally, if you have any comments on this video, or if you want me to play any other cases, let me know in the comment section down below. This has been Juan, and remember, live life to the fullest, because you only have one life to live.
Na 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 na.